This is Namita Setmhota for NEJM Catalyst. I am speaking today with Dr. Rishi Sikka, President of System Enterprises at Sutter Health, a large nonprofit health system based in Northern California, known for its integrated, patient-centered approach in caring for the communities it serves. Today, we will be discussing the opportunities and challenges of leading a health system that is reimbursed for the care it provides patients under both fee-for-service and value-based contracts. It is a common scenario that most healthcare delivery systems grapple with daily. And Dr. Sikka, thank you for joining us because our audience will definitely benefit from hearing your insights. Thank you.
Thank you so much, Namita. It's great to be here.
Let's start by setting some context. Tell us a little bit about Sutter Health and where you are on this journey towards evolving to value-based care.
Yeah, thank you. So Sutter Health is an integrated delivery system. We are based out of Sacramento, and we provide the majority of our care in Northern California. We have a few small exceptions. We do have some services and care that we provide actually in Hawaii and in Southern California. Sutter Health, like most integrated delivery systems, we have a collection of capabilities. We have 24 hospitals. We have 35 ambulatory surgery centers and 2 surgical hospitals, which are part of the portfolio that I oversee. We have 8 behavioral health centers, including 2 freestanding psychiatric hospitals. That's also part of System Enterprise. We also have one of the largest home health and hospice organizations in the country. We saw over 650,000 patients home health visits in 2019 and well over 200,000 hospice visits in our organization. So that's a little bit about Sutter Health, I guess, sort of from a capabilities perspective. In terms of where we are in value-based care, right now about 20% of our lives, of our business is in value-based care. We do have our own health plan. We have a commercial HMO product in the Northern California market, Sutter Health Plus. We do also have a narrow network joint venture product in the PPO space with Aetna. We also have our own employees in a health plan as well. We have about 50,000, so just a little bit, we have about 90,000 lives in our commercial HMO product. We also do have various Medicare Advantage arrangements. We have about 50,000 lives in Medicare Advantage arrangements. A couple months ago, we recently launched an aligned Medicare Advantage product with Alignment Health Plan. So that's a little bit newer for us as an organization. We do have a glide path and an intentionality for our portion of value-based care to increase over the next 4 to 5 years, and we're aspiring to have about 60% of our arrangements, 60% of our business to be in value-based care within about a 4 to 5 year time frame.
How did you decide that time frame? How did you figure out how fast or how slow to move into value-based contracts?
Yeah, that's a great question. So part of it is our understanding of where the market is going and what we think would be possible from a market perspective, and a lot of that is actually driven by the plans themselves, and in the commercial space by self-insured and fully insured employers. I would say the other piece that we're balancing against that is getting our capability set and our abilities robust enough and deep enough and functioning at a level so that we can manage that level of value-based care effectively, both from a quality perspective and then from a total cost of care perspective.
So the 2 drivers in terms of that pace of change are obviously your local market, and then there's what you also mentioned in terms of your internal capabilities. What are some markers of knowing that you are deep enough? What are some of those capabilities? How do you know, how mature do they have to be in order for you to say with confidence that, yes, we can accept more risk than we could before?
Yeah. So I think one of the big steps that we took about a year ago. We set up a new division. It is part of System Enterprise called Sutter Population Health Services. So a lot of the different capabilities that you might call, quote, population health, which it's kind of it's a buzzword, it's an all-encompassing term. I'd rather say, the collection of clinical capabilities that can supplement a physician practice to be able to effectively deliver on quality and total cost of care in value-based arrangements. Those capabilities, they were kind of dispersed throughout the organization. In some cases, they had existed for many years. So what we did is we took those different capabilities and we put them into one organization, under one leader, and set that up about a year ago. So some of those capabilities are, ambulatory care management, having care managers embedded within physician practices who target patients who are at particular risk for adverse or unnecessary utilization, and then working with the physician and reaching out to them. We've had a telephonic disease management program as well that allows us to manage patients with diabetes and hypertension and titrate their medications. We have an inpatient care management program as well. We also oversee a PACE program, programs for all-inclusive care for elderly, for dual-eligible Medicare and Medicaid patients as well. So those are some of the pieces that we've brought together in this division. We have more capabilities that we'll be bringing in, more pieces that we will be developing. Right now, we're in a process of assessing the effectiveness of these pieces, and in some cases doing some redesign and rebuild so that we know that they're actually yielding outcomes.
Let me bring us back to the overarching theme of today around this tension between providing care in both an environment where you're reimbursed in some cases 20% for 20% of your patients in value-based care, and then the other 80 in fee-for-service. Walk us through some of the challenges that you all at Sutter, and quite frankly most of our colleagues around the country are facing in terms of providing care under these respective arrangements, given that they have different incentives, different requirements, and terms.
Yeah, I think one of the key things that we need to do, and I'm speaking in sort of very broad terms, including as an industry, is we actually need to call out and discuss the tension and refrain from using buzzwords or euphemisms that I think mask the dilemma. One of the things over the years that I've heard physicians say so many times, or a variation of this, is something like, well, in value-based care, it's easier to do the right thing. Or when I have a capitated patient, I can do the right thing. And people will kind of throw out that statement, but just take a step back for a second with that statement, right? Like, I don't know anybody who goes into work and says, well, I want to do the wrong thing today, right? So what is that statement of, well, in this situation, I can do the right thing, or it's easier to do the right thing? What are they saying? And if we don't actually, parse that out and unpack it and really say what we're meaning, we don't call out the tension. And I think what people are trying to say, or what people want to say, is that when I have a patient who is capitated, we can provide resources, services, devote a level of time, energy, and effort that would otherwise not be reimbursed in fee-for-service or generate an RVU. And if we can start to actually say something, instead of saying it's easier to do the right thing and then move on in the conversation, if we can start to get away from that kind of phrase and actually unpack it and say what we're meaning, it actually is the first step, which is calling out the tension, right? Mm-hmm. And then when you call out the tension, I think it lends to two things, is being able to do something about it. And the other piece is there's nothing wrong with tension, right? Tension can be very good. Tension can be productive. Tension can be constructive. It's all in how it's managed.
Let me double click on that and I'm naming the tension, and I'm going to name it with a very real example, and then tell me how you all negotiate this every day, because it happens in hospitals, which is there's this inherent tension between a inpatient hospital administrator who needs to keep the beds full, right, with the ACO or the pop health executive whose incentives and goals are to keep that their patient population out of that very same hospital. They both work for Sutter Health. You're all sitting around the same executive table. And again, this is not taking away from the North Star of everybody wants to provide great care. So that is always the goal. But when you dig deeper, their attention around that executive table, what do you do in that situation?
Yeah, and sort of first caveat or mea culpa, I don't think we have it figured out perfectly, and it's definitely a work in progress. For those levels of leadership in an organization, hopefully do not play itself out directly on an individual patient decision basis. So, but where that should and probably does play itself out is on pieces around who pays for what in terms of resourcing and infrastructure, who gets credit for what from a quality or financial based perspective, who gets to make, going to your earlier question and statement, who gets to make some of the decisions with respect to strategy, tempo, and movement in value-based care. So hopefully that's where and hopefully it is, productive tension is playing itself out. I think two of the most important things that we can do as an organization is to clarify decision-making rights. Where does sort of the decision on the tempo and the contracts and the degree of risk, who gets to make that decision in an organization? I think one of the second most important pieces we can do is to clarify where does the resourcing, both from a bodies and ultimately from a financial perspective, where does that decision get made, but more importantly, where does the resourcing, where does the money come from reside? I think one of the things that we did with establishing this new division is that it was an explicit call out that the resourcing for population health would be separate from the funding of it would be separate directly from some of the other aspects of the delivery system. And then the last piece, I think, again, that needs to be talked about or resolved or as part of the management of the tension is really around incentive alignment. That's a piece that we're actually actively working through. How do people get rewarded, and how do those rewards accrue, and on what basis, so that you can move an organization in the right direction?
I really appreciate you making these comments, because we often talk about what the work is, and what you're highlighting is that how the work is organized, the governance, the organizational structure, the incentives, all also need to be paid careful attention, and to make sure that there is alignment. And that is hard. That is complex, hard work. And in terms of how you all have organized things in terms of making a separate structure has been a design choice. And we won't have time today to talk about it, but I imagine that there are potential unintended consequences and challenges that are going to come from a design choice that you've made a year ago, and that you'll have to mitigate against, because, as you know, no model is perfect. Let us wrap up on an optimistic note, which is, as you look ahead, What are you most excited about in the next 5 to 10 years as it pertains to pace of change towards models and contracts that are going to help us realize our goals for improved patient care for individuals and populations?
I will speak about something that's very nascent work, but I think it's just so important to our mission and our success that we're working on, and I know we will have a fully developed approach within the time frame you're asking about, and it's to tackle this area about the social determinants of health. Again, just to go back again, I even though I just used it, I do not like that word. I do not like that word because it is, again, one of these euphemisms, and we just put it out there and then we walk away. And it's, again, one of these examples where we actually need to talk about what we really mean. Mm-hmm. And we're talking then, when we say that we're going to address the social determinants of health, that means that we're going to help our patients and our communities with hunger, with homelessness, with housing instability, with not being able to get to see the doctor, not being able to get to see them, not to get them home. We're going to help them maybe get a job. We're going to help them get good food. And those are like, to talk about hunger, right? That's not something that probably even occurs necessarily in a day-to-day practice setting as well. But if we can start to use that language, those words, and if we can systematically, for lack of a better word, it sounds cold, but if we could systematically screen our patients for these issues, and if we can help them, I know help is a broad term. It could encompass connecting them to resources. It could encompass us connecting them to resources which we help fund. It could be connecting them to resources that we provide. That's the kind of thing that's going to actually ultimately make you successful in value-based care and bending the cost curve, because as you know, only about 20% of what we are doing is going to really impact an individual's health. All these efforts, they're important, they're worthwhile. You have to ensure that they work and that you're not, having regression to the mean effects and, things like that. But it's all of that other stuff that is going to fundamentally make you successful in value-based arrangements. So I am really excited that we are looking forward on doing something like this for our organization, for our communities, and I think it fits in with the not-for-profit mission of our organization and other delivery systems too. I'm really stoked about that.
We appreciate your time and your insights. Thank you so much, Dr. Sicca, for speaking with NEJM Catalyst today.
Thank you so much, Namita.